Dr. Julien is one of North America's top interventional radiologists. He's the talent behind a booming South Florida practice with extensive knowledge dealing with vein disease. An expert in dealing with varicosities, Dr. Julien is now developing a strong campaign to educate patients about varicoceles, the swelling in the veins above the testicles. On a recent trip to South Florida, Dr. Julien invited me to his practice to discuss varicosity treatment options, how varicoceles are diagnosed, symptoms, and how minimally invasive techniques are now influencing treatment options.
Varicoceles have come into the radar of best vein care, and since you are an expert in this field and you have a successful practice in South Florida, I'd like you to basically give us a brief about varicoceles. What is a varicocele, for example?
A varicosity is an abnormal dilated vein that's under a lot of pressure. Most of the time when you think about varicosities, you're thinking about leg varicose veins, and in that situation there are these abnormal pathways that are letting blood pour the wrong direction down towards your feet, and so because the valves are broken, the valves which are supposed to let the blood only go up towards the heart, they become defective or incompetent, so that when you stand up, blood pours down these pathways and fills the varicosities. They can cause problems such as being ugly, a cosmetic problem, but it also in a lot of situations causes symptoms. So people will complain about pain, particularly towards the end of the day. They have achiness, cramping, sometimes their leg swells. In advanced cases, they'll start to get changes in the skin. It gets fibrotic and brown near the ankle, and you can actually get very painful wounds, which can be quite debilitating, and people will end up losing a lot of time from work and may not be able to work. Another area that's pretty dramatic is sometimes the veins can pop and bleed, and then you have a medical emergency.
Okay, so let's get into the discussion about varicoceles.
Okay.
Let's just educate the public. What are varicoceles?
We were talking about varicose veins in the legs, but there's veins all over the body. And there's another example of varicose veins that men get in their scrotum, and that's called a varicocele. And it can cause problems ranging from being ugly because you have worm-like veins in your scrotum, but can also cause symptoms of pain and discomfort and achiness and heaviness. The testicle can atrophy, particularly concerning in adolescents. And in some cases, the sperm count may be abnormal, maybe a low sperm count, or maybe the motility of the sperm is not optimal, so people can have problems with the infertility. And so that's sort of the spectrum of the problems that a varicocele can cause. Traditionally, that's treated in the United States by urologists who will make a little incision near the inguinal ligament in the groin area and will clip that vein, much like a ligating and stripping procedure might be in a leg. We can use our interventional techniques to treat this in a minimally invasive way. The way an interventional radiologist would do it is we would get access to the venous system, either the jugular vein or through a femoral vein, and then we would thread a catheter up towards the renal vein and identify where the gonadal vein is and confirm that it's an incompetent abnormal vein, and then we would advance our catheter under X-ray guidance down the gonadal vein to the inguinal ligament. And there we would go and basically close off the vein from the inside. There's a number of techniques to do it. Probably the most state-of-the-art today is putting in what's called a coil, which is a wire that has memory. So as you push it through your catheter, it forms a coil and plugs the vein. Then we'll inject some sclerosant, the Sotradecol, and then we might put another several coils in. And so essentially you've plugged the gonadal vein up both by mechanically with the coils, but also you've killed the little pathways and damaged the vein with sclerosant. So you basically have eliminated the pathway of blood flow into the scrotum.
How are varicoceles diagnosed?
They're diagnosed by both physical exam and also with ultrasound. So much like a phlebologist who's studying leg veins would look for reflux in varicose veins and pathways, you can look for the varicose veins in the scrotum with ultrasound, and you can actually see the reflux.
Would they need any sort of repairing? I mean, is this like continual treatment?
Well, one of the problems with surgical repair is that when the urologist ligates the gonadal vein, sometimes there can be a small branch that they won't see, and there can be recurrences. With the interventional techniques, we really don't seem to have that problem very often. And so there certainly can be a recurrence, but it's uncommon. The other nice thing about embolization, which means plugging up the vessel, is that it's done under local anesthesia, sometimes with some mild sedation. And when you're done, you have a Band-Aid either on your neck where the jugular vein is or on the groin where the femoral vein is.
When it comes to actually repairing a varicocele, how do you repair that?
The strategy on a varicocele is you have to shut down the gonadal vein and get rid of that refluxing pathway. So that can either be done surgically with the ligation or with interventional techniques where you occlude it from the inside, typically with coils and sclerosants. Now, we don't generally go into the scrotum and remove the varicose veins because that would increase the morbidity of the procedure, and instead we just rely on the veins decompressing. And so you just shut down the gonadal vein and those veins will decompress and get much, much, much smaller.
What are the risks and complications associated to varicoceles?
It's one of the simplest, safest procedures we do. We can do it in an office-based setting, like I do, and there's a small risk of infection, a small risk of an allergic reaction from the contrast dye. There's a remote risk of one of the coils breaking free, but in general, it's extremely well tolerated and very safe. The procedure is almost universally successful from a technical standpoint, but also from relief of symptoms. Now, if the problem is infertility, generally the sperm count will improve and the motility will improve, but doing gonadal vein embolization is not necessarily going to cause a pregnancy, but it will certainly improve the sperm count.
Now, one comes in, gets the procedure done. As far as activities, wound care, medication, how should they follow through?
We'll tell them to take it easy for a couple days, and then they can start their activities back to what they were before. If there's someone who likes to weight lift or do real exertional activities, we might tell them to tone down on that for a week or so.
Now, let's talk about the importance of an interventional radiologist doing these types of procedures.
So as an interventional radiologist, we have a comprehensive understanding of the venous and arterial system of the entire body. A lot of the people who are dealing with varicose veins, for instance, come from a lot of different backgrounds: family practice, internal medicine, anesthesia, ER doctors, surgeons. They can be trained to do pretty reasonable work, I think, for the lower extremity varicose veins, but that's just the tip of the iceberg with vein problems in the body. And as an interventional radiologist, I think we take a more comprehensive view. And just to discuss some of those problems that people have, those clinical conditions and how they can be treated, I could just go through a few areas. We talked about varicose veins in the legs. We just talked about varicoceles caused by gonadal vein reflux. Well, there's a woman equivalent to varicoceles, and that's something called pelvic congestion syndrome. And in that situation, the gonadal vein, the same vein that causes a varicocele, is incompetent, and the blood pours down into the pelvis, into varicose veins in the pelvis. Now, it's much harder to diagnose because you can't see those varicose veins because they're inside the abdominal cavity, but the woman might complain of heaviness and achiness and unexplained abdominal pain. And in that situation, it's treated almost identical to a varicocele, where we go through with a catheter into the gonadal vein and we occlude it with coils and sclerosants, and we can treat that clinical condition. There's other problems that occur in veins, that like a clot in a leg vein. That's called deep vein thrombosis. That's a dangerous condition. You can also have obstruction of the venous drainage of the deep system of the legs, and so you can have a lot of symptoms related to leg swelling. Even if the leg gets better, oftentimes over the rest of a patient's lifetime, they may have recurrent problems because that vein was obstructed and the valves were damaged. So there's some techniques now where we treat these clots in the deep system, and those would include putting little catheters inside those veins and injecting clot-busting drugs, or using some mechanical devices that help dissolve the clot, and so you can restore normal blood flow. Importantly, when we do this, you want to do it within a 2-week period of the diagnosis, because even if you can successfully get rid of the clot after that, a lot of times the valves are damaged in the deep system and you'll have a lot of problems with leg swelling long term. So if someone has a significant deep vein thrombosis, and so I'm not talking about a small tibial vein, I'm talking usually a vein in the thigh, the femoral vein or the common femoral or the iliac vein or even the inferior vena cava, those can be quite debilitating. And so we're becoming a lot more aggressive about treating those with different thrombolytic techniques. In addition, we sometimes will put in devices called filters, which is a small, it looks a lot like an umbrella without the material. We put those in the inferior vena cava in the abdomen, and those will catch clots and keep them from going to the lungs. It used to be that they were a permanent device, but those permanent devices have complications. They can increase the risk of having recurrent clots, recurrent deep vein thrombosis, and you can also clot the filter off and occlude the cava, which can be very debilitating with both your legs swelling. So in a lot of situations, after the clot has been treated, we will then go back and remove these filters. They're called retrievable filters. Generally, that's pretty straightforward. You can actually do that in an office setting. You can put filters in the office and you can remove them in an office setting. The point being, these are both minimally invasive procedures. If a clot breaks off in the legs, it can lodge in the lung, and that's called pulmonary embolism. That can cause shortness of breath and chest pain. It can even result in circulatory collapse and the patient can die. So in that situation, we can treat those clots with clot-busting agents as well. We can put little catheters through the bloodstream, thread them through the bloodstream into the lungs, and inject medications, clot-busting drugs, put little catheters in to dissolve them, and oftentimes save a patient's life. The field of embolization is very broad. In good hands, it's extremely safe, but if you're not well trained, there's a lot of risks involved. You need to be able to understand all the different embolization, the liquids, the particles, the coils, the plugs. So we have these devices called Amplatz plugs. You need to know how to size them. You need to know which devices to use in which vascular bed.